All right, if you're in healthcare, you are going to see serotonin syndrome. It's really not a matter of if, but when. And since some of the most common drugs in the world are the cause, knowing how to spot it can literally be the difference between a minor side effect and a life or death emergency. So let's break down exactly what you need to know.
So this is the big question, right? Is serotonin syndrome just another side effect you rattle off, or is it a full-blown medical emergency? And the answer is, well, it's both. It exists on this whole spectrum, from really mild anxiety and tremors that are super easy to dismiss, all the way to a catastrophic state of high fever and organ failure. Understanding this spectrum is absolutely key to catching it early.
So to really get a handle on this, we're going to follow the problem from start to finish. We'll start by defining what it is, then we'll dive down to the microscopic level to see what's happening. After that, we'll learn how to spot the classic signs. Then we'll name the common culprits, lay out the emergency management plan, and wrap it all up with how to prevent it from happening in the first place.
Okay, let's start with the absolute basics. When we strip away all the jargon, what exactly is serotonin syndrome?
At its very core, serotonin syndrome is simply a state of serotonin toxicity. It's not some kind of weird allergic reaction. It's a predictable, expected consequence of having way too much serotonin activity in the body. And the key thing to remember here is how fast it happens. It's rapid, usually popping up within hours, sometimes even just minutes, after taking a new serotoninergic drug or upping the dose of one.
But here's the kicker. The official numbers probably don't even come close to the real story. Serotonin syndrome is thought to be seriously underreported. Why? Well, because the mild cases, a little anxiety, some shakiness, they often get brushed off as just normal side effects. But get this, one study of older adults in a geriatric unit found that a whopping 25.2%, that's 1 in 4 patients on antidepressants, showed signs of it. It is way more common than most of us think. Okay, so we know what it is, but to really get it, we need to understand why it happens. Let's zoom in from the big picture at the bedside, all the way down to the tiny, microscopic world of the brain's synapses. This image shows us exactly where all the trouble starts. In the synaptic cleft, that tiny little gap between nerve cells. Normally, a neuron squirts out some serotonin, it floats across the gap to hit receptors on the next cell, and then it gets cleaned up. But in serotonin syndrome, you have a massive flood of serotonin just hanging out in this gap. This leads to this constant, overwhelming stimulation of the postsynaptic receptors, especially the 5-HT1A and 5-H2A types. This biological short circuit is what causes all the chaos we see in the patient. So how does this overload actually happen? Well, there are basically 5 main ways things can go wrong. Drugs can either crank up the production or release of serotonin, or they can just directly hit the receptors themselves. They can also stop serotonin from being broken down, which is what MAIs do, but the most common mechanism by a long shot is number 2, blocking the reuptake. This is exactly what SSRIs do. They gum up the works of the little vacuum cleaner that normally removes serotonin from the synapse, leaving way too much of it active for way too long. So that's the microscopic chaos. Now let's pull the camera back out to the bedside and see how this actually looks in a real person.
The classic clinical picture is described by a triad of symptoms. First up, altered mental status. The patient might seem really agitated, anxious, or just confused. Second, neuromuscular problems. This one is huge. You're looking for tremors, overactive reflexes, and especially clonus, that rhythmic, involuntary muscle contraction. Clonus is a hallmark sign. You have to look for it. And third, you've got autonomic hyperactivity, where the body's automatic systems just go haywire, causing a racing heart, high blood pressure, fever, and tons of sweating.
And it is so important to remember this is not an all-or-nothing thing. It exists on a continuum. A patient might just show up with a mild tremor and some anxiety on the far left side of this spectrum. But if you don't recognize it, or worse, if more serotonergic drugs are given, they can slide right over to the other side, developing a life-threatening high temperature and nonstop clonus. So how do we actually make the call? How do we diagnose it? This is where the Hunter criteria are your absolute best friend. They're super specific and really practical. If your patient is on a serotonergic drug and has any one of these findings, you've got your diagnosis. And just look at how powerful clonus is here. If a patient has spontaneous clonus, that's it. Boom, you don't need anything else. This tool is how you move from just a suspicion to a confident diagnosis right at the bedside. Okay, so we know what to look for. Now let's talk about the usual suspects. Which drugs are most likely to get our patients into trouble?
The biggest category, and this will be no surprise, is psychiatric medications. I mean, this list includes some of the most prescribed drugs on the planet, like the SSRIs, sertraline and fluoxetine. It's really critical to know that while any of these can be a player, the MAOIs are notorious for being involved in the absolute worst cases, especially when they're combined with other serotonergic drugs. But the risk goes way beyond psychiatry. Common pain medications, especially opioids like tramadol and fentanyl, they have serotonergic activity too. In fact, one of the most classic dangerous combos you'll see is someone on an SSRI who also gets prescribed tramadol for pain. We also see a risk with the triptan class of drugs that are used all the time for migraines. And this is exactly why you have to be a detective when you take a medication history. It's not just about what's prescribed. Over-the-counter supplements like St. John's wort are a well-known risk, so are recreational drugs like MDMA, but it can even be triggered by things you'd never suspect, like the antibiotic linezolid, or even the incredibly common anti-nausea drug ondansetron. Okay, so we've spotted the syndrome, we have a good idea what caused it. Now what do we actually do? This is an emergency, and we need to act fast. The management plan is pretty straightforward, but you have to be quick. First, and this is without a doubt the most important step, stop all serotonergic agents. Just doing this one thing can resolve mild cases all on its own. Next, you support the patient. Give them oxygen, IV fluids, and start actively cooling them if there's a fever. To get the agitation and that muscle hyperactivity under control, benzodiazepines are your go-to drug. If things start getting really serious, you can reach for a specific antidote called ciproheptine. And finally, every single one of these patients needs to be observed. You can't just send them home. Now, just as important as knowing what to do is knowing what not to do. And there are some classic mistakes. Using antipyretics, like acetaminophen, is a big one. The fever isn't coming from the brain's thermostat being reset. It's being generated by all that intense muscle activity, so Tylenol won't do a thing. Physically restraining an agitated patient can actually make it worse by increasing muscle breakdown. And a few other drugs like propranolol and succinylcholine carry some really specific, dangerous risks in this situation. Being able to tell serotonin syndrome apart from its lookalikes is absolutely critical. And the key clues are usually in how fast it starts and what you find on your physical exam. Look at the biggest difference with neuroleptic malignant syndrome. Serotonin syndrome is fast, less than a day, while NMS is slow, developing over days to weeks. And the muscle exam is the total opposite. Hyperactivity in SS versus that stiff lead pipe rigidity in NMS. And when you're comparing it to anticholinergic toxicity, just remember the old rhyme. Those patients are dry as a bone, while our serotonin syndrome patients are sweaty and have hyperactive bowel sounds. Finally, let's bring it all home. What's the outlook for these patients? And, maybe even more importantly, how do we stop this from ever happening to begin with? And this is the really great news. Even though this condition can be incredibly dangerous, if you catch it early and manage it properly, the prognosis is excellent. The mortality rate is less than 1%, and most people with mild to moderate cases get completely better within 24 to 72 hours of stopping the drug and getting some supportive care. But at the end of the day, the best way to treat this is to prevent it from ever happening. And that all starts with a super careful medication review, asking not just about prescriptions, but about over-the-counter drugs and supplements too. It means being really careful about risky combinations, respecting washout periods when you switch antidepressants, and this is a big one, educating our patients so they can be partners in keeping themselves safe. So I'll just leave you with this thought. Tramadol, sertraline, ondansetron, dextromethorphan, these are not rare drugs. They are used every single day in every hospital and clinic. The next time you see them on a patient's medication list, will you pause for a second and recognize the potential risk? Just asking that simple question is what makes all the difference. Thanks for tuning in.